So now you have resuscitated that patient. After resuscitation, you have to monitor that patient. In this section, we'll talk about monitoring of a patient with shock. We'll deal with the cardiovascular system monitoring, and then we'll talk about central venous pressures. After that, we'll talk about systemic and organ perfusion and how to manage that. Finally, we'll talk about various methods through which we can take the efficacy of our treatment. So the monitoring for a shock patient, the minimum monitoring requires an ECG, a pulse oximetry, a blood pressure, and a urine output. So this is the minimum that is required for a patient in shock. A continuous ECG rhythm, pulse oximetry to give you the oxygen saturation, the blood pressure, and the urine output. Now, additional modalities might include the central venous pressures, the invasive blood pressures, the cardiac output, and base deficit and serum lactate. So it's good to be prepared, but a minimum of what is required should always be done. Now, the cardiovascular monitoring. The minimum, it's a continuous ECG. This continuous ECG helps you to understand the heart rhythm and the heart rhythm, the heart rate, and it's very helpful in maintenance of the patient. The oxygen saturation, usually done by the pulse oximetry. Now the pulse waveform, we always look for it, that how the pulse waveform is, so that we can get an idea of the function of the heart. Then the non-invasive blood pressure, obviously, though the blood pressure is lowered very late in shock, however, this measurement of blood pressure is very helpful. Now, additional measurements might include the central venous pressure, the continuous blood pressure monitoring. Now, the central venous pressure and the continuous blood pressure monitoring might be done, but they're not necessarily required. So moving on to central venous pressure. So central venous pressure is shown this graph in the figure. It helps to it is actually the right atrial pressure, the pressure of the blood that is returning to the heart. Now there's no fixed value of central venous pressure. Some patients may require a central venous pressure of 5 centimeter water. Now, some may require central venous pressure of 12 centimeter of water or higher. Now, the ventricle compliance can change from minute to minute in a shocked state. So, obviously, the heart may respond differently each minute. Now, CVP, or the central venous pressure, is a poor reflection of the end diastolic volume, that is the preload. It does not completely give you an idea of the preload. Now, CVP measurement should be assessed dynamically as a response to the fluid challenge. So fluid challenge is something that is done, and the response to fluid challenge is checked by the CVP. This response to fluid challenge assesses the response to the treatment of shock of the patient. Now, what is the fluid challenge? A fluid bolus of 200 to 500 ml is infused rapidly over 5 to 10 minutes. Now, the normal CVP response is a rise of 2 to 5 centimeter of water, which gradually drifts back to the original baseline state within 10 to 20 minutes. Now, patients with no change in CVP are empty, that is, they require further fluid resuscitation. And patients with a large sustained increase in CVP, they show a high preload and an element of cardiac insufficiency or volume overload. So, with the response to this fluid challenge, you can assess the functioning of the body and the need for the fluid therapy, the further need for the fluid therapy. Now, moving on, monitoring of the cardiac output, it allows assessment of the systemic vascular resistance and the end diastolic volume, as well as the blood volume. Now, invasive cardiac monitoring can be done with pulmonary artery catheters. However, these catheters are not being used now because of their invasive nature. Now, Doppler ultrasound, pulse waveform analysis, and indicator dilution methods are being more commonly used. Now, they help distinguish the types of shock present. They provide the guidelines for fluid and vasopressor therapy. Now, in desirable patients who do not respond, these conditions, these modalities are desirable in patients who are not responding to the first line therapy or cardiogenic shock or myocardial dysfunction. So a measurement of cardiac output would be helpful in these patients. Now, let's see what are the clinical signs and what investigations can be used in the shock. So in order to check systemic perfusion, there are no clinical signs as such. However, we can look for the base deficit, the lactate, the blood lactate, and mixed venous oxygen saturation. So the base deficit is actually the difference between the acid and the basic components in the blood. It increases with the accumulation of lactic acid in the body. Lactic acid accumulates due to anaerobic respiration, and this anaerobic respiration is due to shock. So the greater the base deficit, the greater the shock is in the body. Now again, lactate in itself is accumulated due to the shock. Increase in lactate increases the severity of shock. So mixed venous oxygen saturation is the amount of oxygen that is consumed in the body. Now, talking about organ perfusion, muscle perfusion cannot be measured clinically. However, investigations that can be used include the near-infrared spectroscopy, now tissue oxygen electrode. These are not done usually. Now, gut perfusion cannot be measured clinically again. However, investigations used that can be used include the sublingual capnometry, the gut mucosal pH, and the laser Doppler flowmetry. The kidney can be clinically measured by urine output. The brain can be clinically measured by the conscious level, and investigations that can be done include the tissue oxygen electrode and near-infrared spectroscopy. Now, base deficit and lactate. So serum lactate level or base deficit is sensitive for both the diagnosis of shock and monitoring the response to the therapy. A base deficit of over more than 6 millimole, it represents higher morbidity and mortality. And the length of time in shock with an increased base deficit is important because it affects the overall prognosis. Greater the length of time in shock with increased base deficit, the worse is the prognosis. Now, mixed venous oxygen saturation, it's the percentage saturation of oxygen which returns to the heart from the body and is a measure of oxygen delivered and extracted by the tissues. Now, blood is drawn by a long central line which is placed in the right atrium. Normal mixed venous oxygen saturation are between 50 to 70%. Levels below 50% indicate inadequate oxygen delivery and increased oxygen extraction by the cells. Now, the cardiac output, if the cardiac output is high, the systemic pressure of oxygen is high, as a result of which we have high conditions with high, we have inflammation, we have excessive blood flow, inflammation as in sepsis, and there's excessive blood flow in hypovolemia and excessive vasoactive therapy. So when it is low, the partial pressure of oxygen is low, we can have anemia, we can have hypoxemia and high partial pressure of oxygen. Now, when the cardiac output is low and the partial pressure of oxygen can either be high, in high partial pressure of oxygen we can have anesthesia and hypothermia. In low, we can have low output syndrome. that is hypovolemia, heart failure, and pulmonary embolism. So this gives you some idea as to what is going on in the body and how to treat it. Now, what are the end points of resuscitation? What tells you to end your resuscitation? So, in initial resuscitation, what are your goals? You need to have hemodynamic and global oxygen delivery. The cardiac output must be maintained, the preload must come to normal, the contractility must increase, the afterload must either decrease or come to normal, the oxygen carrying capacity must increase, and the arterial oxygen saturation must increase. Now, the microcirculatory considerations that you should consider are the endothelial dysfunction that would occur if the blood supply is disrupted, the impaired RBC deformability, because if the RBC is not getting sufficient ATP, it would lyse. Now, the rolling in addition of RBC and WBC to the endothelium, because a damaged endothelium becomes sticky and they roll and attach to it. There's altered glycocalyx of the bacteria, and finally we have impaired backward communication. Now, effective resuscitation can be checked with the lactate, with base deficit, with pH. The organ failure might be improving, the partial pressures of oxygen might improve, and the endothelial signaling might come back to normal. So, at the end of resuscitation, your patient might not be walking and talking, but the patient might be stabilized. The end of resuscitation is marked either by stabilization of the patient, or either by expiry of the patient. Whatever end of the spectrum you might arrive at, you must have given your best to resuscitate the patient, because that is what is your duty as a doctor is. So this was all about this section. In this section, we talked about the maintenance of a resuscitated patient with shock. We saw what parameters need to be monitored, what parameters are used for assessment of the shock, and how you can maintain your patient and how you can end your resuscitation. I hope you enjoyed and liked this lecture. For further such lectures, keep watching sqadia.com.